is Jessie. I'm going to be talking today a little bit about postpartum pelvic health and physical therapy, whether it's 6 weeks after you had your baby or 6 years, 10 years, doesn't really matter. So a little bit more about me. I was born and raised in Summit, and I went to Summit High School. After that, I went to the University of Scranton, and I got a Bachelor's of Science in Exercise Science. After that, I went to the University of Miami and got a doctorate of physical therapy from there. And now I'm currently working at Summit Physical Therapy, and I started here in May. Some of my hobbies include yoga, hiking, watching movies, cooking, and reading. And then I just threw in a little picture of me in high school as a cheerleader. So I was a cheerleader. Okay, so let's start with a really big question I feel like a lot of people ask is, what is your pelvic floor? So the pelvic floor is a region. So it starts in the pelvic girdle. So from your hips all the way down to your pubic symphysis. So you have a lot of different joints in that area of the body. A lot of people are familiar with the sacroiliac joint, the SI joint, which is in the back. And then you have your pubic symphysis in the front. The pelvic bowl itself is the whole area in between. So that's kind of where your reproductive and urinary and bowel organs are. And then you have the floor of that whole region, which is referred to as the pelvic floor. So that pelvic girdle is super important for transmitting weight in standing and when you're walking from your trunk, which is, everything above your hips, into your legs. It supports your body when you're sitting. And then it also is where a lot of the muscles from your hips and your trunk are attached. So it's not just the muscles of what I'm going to go into as the pelvic floor, the pelvic diaphragm. And it's there to protect all those organs that I mentioned before, reproductive organs, your bladder, your rectum. And then, so at the bottom of that area, you have the floor, which is starting from the inferior part of your abdomen. So your peritoneum, the lining of your abdominal cavity. And then underneath that, you have your pelvic floor muscles, which is skeletal muscle, just like the other muscles in your body that help with movement. And then you also have a lot of fascia or connective tissue in between all those different layers that I'm going to go into a little bit. And then you have a lot of ligaments in that area, in addition to all the ligaments that are attaching your low back, your femur and your hips. And then the bottom of that floor is just the skin of your vulva and your perineum. So I have some pictures. So this larger picture at the top shows two different sides. So on the left, you can see all of the superficial muscles of your pelvic floor. So bulbocavernosus, ischiocavernosus, and the perineal membrane. All of those are kind of closer to the skin. And then on the other side, you can see the deeper muscles of the pelvic floor, which are referred to as a group as your levator ani, and those are responsible for continence and support of the muscles, not the muscles, the organs in that area. And we'll go a little more into the function of those in a little bit. And then down in the corner, you can see that there's a lot of different fascial connective tissue structures going in between the organs as well. So there's a lot of support, both muscular and passive connective tissue support in that area. And then I threw in this picture at the bottom because it shows a lot of the muscles coming from outside of that pelvic girdle region, but are attaching into that same area. So your hip external rotators, your hamstrings, your adductors, and your hip flexors all are going from outside into that area and attaching there. So what does it do? What is your pelvic floor for? So there's three main functions of the pelvic floor. It's there for support and stability. It's there for sphincteric control, and then it's there for sexual function. So for support, like I said before, it's literally holding up all of those organs in that pelvic cavity. And then it's also the location of your center of gravity. So all of that weight in standing and when you're, even sitting and walking is located in that perineal tendon, which is like where the center of all of your muscles actually attach in that pelvic floor area. And then it's also super important for generating intra-abdominal pressure. So it works with your respiratory diaphragm and your deep core muscle, your transverse abdominis, as well as your deep lumbar rotators to help provide pressure when you're really doing anything, whether it's sitting, standing, walking, especially when you're exerting a lot more force, like lifting something heavy. And so if any of those structures, the pelvic floor, the abdomen isn't strong, you're going to have a weakness and a poor ability to generate that pressure. And then you are at risk for a back injury or a pelvic floor injury. The way it was described to me was that the weakest link is the one that's going to fall apart first. So if your pelvic floor is weak and then you're still generating that pressure, it's going to go down into the pelvic floor and then you're going to have issues there. So the other function is sphincteric control. So like I mentioned before, it's in charge of continence. So it's going to contribute to urinary continence and providing pressure of your urethra to kind of control it in that way. And then it also is controlling your rectal function. So those levator ani that we saw in the picture in the last slide are literally being like cupped and held by those muscles. I threw in this picture on the side and it shows you 3 tiny little muscles that are surrounding the vagina and the urethra to help provide some of that continence control. And it's voluntary and involuntary. So there is stuff that can be done to help control that if one of those muscles is at fault. And then the other thing with the sphincteric control is that in order for you to have voiding or defecation or childbirth, you need to be able to fully relax your diaphragm, your pelvic diaphragm. So that's something I'll go into a little bit further with when I talk about incontinence. And then sexual function, like for example, your superficial pelvic floor muscles are in charge of arousal. So a lot of them pull and tug on a couple different things to get that going. Okay, so I'm going to go over some changes that happen during pregnancy. I'm not going to go through all of them, but just kind of the stuff that I feel is important for you to know for when we continue with the presentation. So I threw in this picture here because in the beginning of pregnancy, you're going to have different changes than at the end of pregnancy. But one of the main things that happens almost immediately is you have a change in where your center of gravity is located. So it moves forward and a little bit up. So that's because you are gaining weight in your abdominal area, right? You're growing a baby, and then your breasts are also getting larger as you prepare for lactation. So you have a lot more weight in the front of your body. So that causes the center of gravity to change. When that happens, when your abdomen is getting bigger, those muscles in the front of your body, your abdominal muscles, are also stretching out. And so it's pretty common for people to have what's called diastasis recti. And that is not normal, but like I said, it's common. And what happens is the connective tissue between your rectus abdominis, the most superficial abdominal muscle you have, actually moves and spreads, so it causes a weakness in the middle of your body, and that should go back to normal after 4 weeks, and sometimes it doesn't, so that's something that can be addressed. And then another big change that happens during pregnancy is that you have increased ligamentous laxity, and that's because of a hormone called relaxin. So that contributes to postural changes. It causes an increase of your natural spinal curve. So everybody has different curves in their spine, but you have an increase of your thoracic curve, which is your upper back, and then you have an increase of your lumbar curve, which is your lower back. So that in addition to all that weight being forward, can add a lot more strain on your low back than someone who isn't having a baby. And it's similar in overweight men too, the same kind of mechanism. It's just they might not have increased laxity. And then that laxity can also contribute to hypermobility or more movement in your joints all over your body. So your SI joint in the low back is something that's commonly affected by this. And then also your pubic symphysis in the front of your body is looser now, which makes sense because it needs to open and widen when you're delivering the baby, but that can be a source of pain later on because those hormonal changes hang around for a little bit after. So these are just a couple examples of the type of postpartum patients that one could see. So there's a lot of different things that people could be wanting to work on. So anywhere from a perineal tear, a laceration while delivering vaginally can lead to things like dyspareunia, which is pain with sexual activity. If it's a really bad tear, a 4th degree tear would be going into the anal sphincters, and that could be causing fecal incontinence. So that might be something somebody wants to address. After a cesarean section, they might want to help with the rehab after that because it's a major surgery. And there's things that we can do, abdominal strengthening, stuff like that, to address that, as well as working on the scar itself, just like any other scar, any other kind of surgery that you would have. Like I said, SI joint dysfunction is pretty common, the diastasis recti. And then even someone without a diastasis recti could come to work on their core because it's still weak after 12 months. And then stress urinary incontinence is just one example of urinary incontinence, and we'll go into a couple more. So some common pelvic floor dysfunction. So I wanted to go over this because I feel like it's super important. I think that sometimes there's people that think that you can only have a weak pelvic floor, which isn't true. So a supportive dysfunction would be a weak pelvic floor could be part of that. So that could be anywhere from loss of integrity of the connective tissue or weak muscles of the pelvic floor. So it could be due to hormonal changes. If you have a connective tissue disorder, then you're already at risk for something like this happening. Repetitive strain, so a lot of heavy lifting or a lot of walking can cause pressure on that area, and cause like a laxity of that tissue. And then those kind of things can lead to urinary incontinence, fecal incontinence, or even pelvic organ prolapse, which we'll go into a little bit more later. So some signs of a supportive dysfunction or an underactive pelvic floor could be incontinence, a feeling of pressure, heaviness, difficulty with orgasms, and then bowel or bladder dysfunction or frequent urinary tract infections. And then on the other end, you can have a hyperactive pelvic floor. So there'd be increased tension in those muscles, which could cause pain in that area. It could also cause difficulty with bowel or bladder function, like constipation, for example. And signs of that are more back pain, vaginal pain, rectal pain, abdominal pain, vulvar burning, pain with sexual activity, and constipation. And then another type of dysfunction would be a non-functioning pelvic floor. So you either are unable to contract or unable to relax or have no kind of motor control over that area of the body. So for pelvic pain is super complicated. It could be something related to any of the structures in that area, and because it's such a large area, it could be really coming from anywhere. So pelvic pain is defined anywhere between the top of your hips down to the bottom of your glute folds. So acute pain is considered less than 3 months. So that could be either urgent or non-urgent. So for example, if someone has a ruptured ovarian cyst or an ectopic pregnancy, that's something that needs to be addressed right away. And then non-urgent could be something like endometriosis, where it's a new pain for you, but it's not like a medical emergency. And that's something that the physical therapist or your doctor will be able to kind of guide you if you need to see some other sort of medical professional, or if that's something that we're able to treat and within our scope of care. So chronic pelvic pain would be considered anything longer than 6 months. And so typically that's not cyclical, so that's not associated with your menstrual cycle. And it has more to do with changes in your central nervous system. So this could be coming from a lot of different places, whether it's gynecological, musculoskeletal, neurological. And then, so some risk factors associated with chronic pain are irregular menstrual cycle, time of onset of your menstrual cycle, so starting early, sexual assault, and depression. So for urinary incontinence, there's a couple different kinds of urinary incontinence. So the most common, I think, postpartum is the stress urinary incontinence, which is what happens when you leak with sudden increases in intra-abdominal pressure. So for example, coughing or sneezing or laughing or picking something up, and you're not able to kind of contract that pelvic floor the way it should be contracted, and you aren't able to control that leakage. Versus urge incontinence is loss with a strong desire to void. Sometimes this can be called overactive bladder when you have the involuntary contractions of your bladder. The muscle in your bladder is called your detursor. So you can have overactive bladder. And then you can have a kind of a mix of both, which is stress incontinence symptoms and urinary incontinence symptoms. And then there's also functional incontinence, which is like you're able to control your pelvic floor, however, you're unable to make it to the bathroom. So whether you're not able to walk quickly enough, or you have some other disability that's preventing you from getting to the bathroom. So another example would be like a cognitive impairment, where you're not able to get yourself into the bathroom in time to use the toilet. And then overflow is you have a loss because your bladder is so full that you can no longer keep your urine in your bladder. So that could be for a couple different reasons, but maybe you're not able to sense that your bladder is full, or there might be something blocking the urethra, or you might just not be able to contract fully. And those are kind of more associated with neurological dysfunctions. So frequent urination is considered anything more than 8 times a day. And so you should be able to hold your bladder for 2 to 5 hours without needing to run to the bathroom, which I know sounds like a lot. And it depends on how much you drink and stuff like that. But in general, they say normal is 4 to 8 times a day. And so for people in their, or women in their first trimester, they have an increase in urinary frequency, and that's just because of hormonal changes. And then when they get into the end of their pregnancy in their 3rd trimester, there's actually just more pressure on the bladder, which is causing them to need to use the bathroom more frequently. So that's normal. Okay, so for pelvic organ prolapse, there's a couple different types of pelvic organ prolapse. So you can have apical, which would be a prolapse of the uterus or the vaginal vault if you've had a hysterectomy. So there's no longer a uterus there. It's just closed at the top of your vagina. And then you can also have a herniation of your intestines into that vaginal canal. So all of that's coming kind of from the top. So I don't know if you can see my arrow, but if you can, it would be anything kind of in here coming and popping in through here. And then an anterior prolapse would be the bladder pushing into the vagina along this way. And you can have just the bladder, you can have the bladder and the urethra. It kind of depends on the severity. And then posterior would be rectocele, would be the rectum pushing into the vaginal wall from behind. And then again, you can also have the intestinal pushing in through here. So I think a common misunderstanding is that people think when they see something coming out of their vagina that it's the organ itself, and it's not. It's the vaginal wall that's being pushed in from that organ. And then there's also rectal prolapse, which is different than rectocele, which would be the rectum itself is prolapsing into the rectum. And there's different levels. So anywhere from into halfway into the vagina is considered a level 1 prolapse. And then a level 2 would be all the way to the vaginal opening, the hymen. And then coming outside of the vagina is a level 3. And then complete inversion of that organ would be a level 4, which is also called a procedentia. So some symptoms associated with pelvic organ prolapse. So a lot of times, if it's really mild, maybe level 1, level 2, you might not notice anything. You might not have any pain. More symptoms are associated with those later grade 3, 4 stages. But some women report a sensation of heaviness or pressure in that area, especially like after walking or standing for a long period of time. So like at the end of the day, they'll also report just like general back pain or pelvic pain, which is kind of hard to localize. They'll also have signs of urinary incontinence. So whether it's a weak stream or they're urinating for a very, very long time, it just takes a long time to empty their bladder. They might feel like they're not able to completely empty their bladder, whether or not they truly can't, or if it just feels like they're not done. And then they can also have some post-void dripping. And so a lot of times what actually happens is people with stress urinary incontinence, if their prolapse is getting worse, it'll actually make their stress incontinence better because it's just pushing on the urethra. So it's actually stopping that leaking from happening. And then people will also have bowel incontinence, urgency, constipation. And some women say they actually need to help. So by putting a finger into their vagina and pushing the organ out of the way in order to actually be able to go to the bathroom. And then a lot of times they'll have pain with sexual function, with penetration, and that tends to be deeper. So some risk factors, this is mostly for pelvic organ prolapse, but I think some of this is also applicable to support dysfunction or an underactive pelvic floor. So vaginal childbirth, especially with a prolonged second stage labor. So first stage labor is just, the contractions. Second stage is that pushing phase, which is anywhere from the full dilation of the 10 centimeters till the birth of the baby. And so for women who have had a child in the past, a prolonged second stage would be considered more than 2 hours. And for women who have never had a child, if it's their first vaginal delivery, then 3 hours is what's considered prolonged. And then having a large baby, so average is 9 pounds. So if you have a really, really big baby, that could put you at risk for tears and other kinds of dysfunctions in the pelvic floor. Also instrumented delivery, so like a forceps delivery could cause a lot of damage to the tissue in that area because, their goal is to get the baby out. They're not really thinking about what's happening to the mother sometimes. The number one factor is parity, so the amount of children that you have. So there's a 4-time risk in women who it's their first child, and then that doubles to 8 times more likely for a pelvic organ prolapse after their second child, and then it shoots up to 9 and 10 after 3 or 4 children. So that definitely has something to do with it. Increasing age, so your risk increases after menopause, and that's because of the decreased estrogen levels. So there's less collagen, which is affecting the connective tissue. So that can affect all that fascia and the ligaments in your pelvic floor region. And then women who are older tend to have a higher number of children. And if they've had a hysterectomy, then that can also put them at risk. Increases in intra-abdominal pressure. So if you have a respiratory disease like COPD or asthma where you're coughing a lot, that's causing a lot of increased pressure on your pelvic floor. So that's something that should be addressed. And then heavy lifting. So if your job requires you to pick up and move boxes constantly throughout the day, then that's also increasing your intra-abdominal pressure. And then straining with constipation. So I think it's kind of common for people sometimes to think that in order to go to the bathroom, they need to push, when in reality, what you need to do is be able to relax those muscles to help go. Increased BMI. So this is not only for women, but men as well. So when you have increased weight, just like how we were talking before with women who are growing a child inside of them, you have a lot more weight and just pressure going through that pelvic floor. So it's going to have to work harder. And if it's not strong enough, then you're going to rely on those connective tissues. And then, like I mentioned before, any kind of connective tissue disorder will already put you at risk as well. So treating the pelvic floor. So a lot of what we're going to do is educate. So depending on what needs to be addressed. So for people with incontinence, it's going to be bladder retraining. And we can do a voiding diary to kind of see where the issues are, how much you're leaking, when you're leaking, why, and try to figure it out together. And then dietary modifications. So there's a lot of foods and drinks that are bladder irritants. So for example, caffeine is one. When you drink caffeine, you need to go to the bathroom more. So maybe we have to address when you're drinking certain things or the type of foods that you're eating to try to decrease that irritability of the bladder and decrease those incontinence symptoms that way. And activity modification as well. So for pelvic organ prolapse, if somebody is used to walking 4 miles, but that causes an increase in their back pain or their pelvic pain, then we might have to reduce that a little bit or find other activities that are a little less weight bearing so that there's not as much of that pressure going through that pelvic floor. Lifestyle changes, things like smoking cessation is going to make a big difference because then you're not going to cough as much and then you're going to reduce the amount of increases in that intra-abdominal pressure. Weight reduction and increasing just exercise overall, in addition to the exercise that we're going to do to address the pelvic floor itself. So with therapeutic exercises of the pelvic floor, we're training strength, we're training endurance, we're training coordination, because you might have a pelvic floor that is strong, but after a long period of time, it gets tired and then it kind of gives out, or you're not able to contract and relax it when you need to relax it, for example, when you're using the restroom. So all of those things are kind of pieces, and depending on what your dysfunction is, we'll have to address it in that way. And then abdominal strengthening, because your abdominals work with your pelvic floor as well. And so especially if you have a diastasis, that's something that we're going to have to work on together. Manual techniques. So just like any other physical therapy to any part of the body, manual techniques are a tool that we can use to help align whatever needs to be aligned. We can work on soft tissue to work on muscles that are tight. So whether that's the pelvic floor or other muscles of the hip, that's something that can be addressed. Scar management, like I said before, whether it's a C-section or you had an episiotomy and it's healing and we need to make sure that the tissue is moving well. Breathing mechanics, so super important that you're able to breathe correctly and there's a right way to breathe. When you're doing exercise, when you're doing your household activities, we want to make sure that the diaphragm and the pelvic floor are working together the way they need to, so that you have good intra-abdominal pressure and you don't injure your back or any other part of your body. And then postural training, so correcting any kind of forward positioning that you might have retained after having the baby or even before. So if you had a postural issue before your pregnancy, then it was probably either exacerbated or, I mean, you know, who knows, like if you already had back pain, you're already at risk for back pain during your pregnancy, and then you're at increased risk for back pain after. So whether or not that happened before your pregnancy, it's something that can be addressed and hopefully get you to where you were before or even better. Okay, so some common errors with pelvic floor training. Two really, really big ones are what's called the Valsalva maneuver. So breath holding, a lot of guys do this when they lift super, super heavy weights to give themselves that lumbar stability, or pushing. Which is not what a pelvic floor contraction is. And a lot of times doctors will say, you know, do some pelvic pelvic floor contractions or do a Kegel. And what they're actually doing is bearing down. And then the other common mistake people do is they'll recruit other muscles, so their glutes, their abdominals, their hip adductors, because they're not able to sense that they're contracting their pelvic floor. During toileting, some stuff that's pretty common, but no good, is hovering over the toilet. So I know like public toilets, people tend to want to squat above it, but you're not able to fully relax the muscles of your leg and your pelvic floor. So that could cause some difficulty with urination. And then similar to above, bearing down or pushing to try to push the urine out is not going to allow your pelvic floor to relax the way it should. And then, so just in case voiding. So if you know you're going to be on the road and you want to pee just because you don't know when the next time you're going to get to a toilet is, what you're actually doing is causing your bladder to forget its full potential for strength. So for stretching. So you might feel like your bladder is full, but what's happening is your bladder is a muscle. So if it's not used to stretching to its normal size, it's going to feel like you're not, it's going to feel like it's full, but it's not actually full. And then holding your urine. So, I don't want to go to the bathroom, maybe because you're in public or something. Or maybe they don't want to drink water because they don't want to have to go to the bathroom frequently. But what you're doing is you're concentrating your urine. So, and that's actually causing irritation to the bladder, and that's going to make you need to go to the bathroom more. So pelvic floor PT. So a lot of the changes that happen to your body when you're pregnant can last for around 2 months after, and some can even stay around for up to a year. And there's research that shows that people who don't return to exercise after have lower abdominal tone. So 52% of their abdominal tone from prior to their pregnancy versus people who return to exercise will have only a 15% decrease in that. And so it returns pretty quickly if you're able to return to physical activity. The number one thing is to get medical clearance. Typically 6 weeks after you have your baby, you're able to start working with a physical therapist. But again, you always want to check with your doctor. So walking is a really great way to return to physical activity. It's low impact, so it's not going to have a lot of pressure. It can help decrease stress urinary incontinence. It can help with weight reduction after the baby. So a cool fact, well, I thought it was a cool fact, is that 70 to 80% of women actually perform a pelvic floor muscle contraction incorrectly. So a lot of women think that they're doing a pelvic floor contraction, but what they're doing is actually something different. So either bearing down or using other muscles. Physical therapy is really, really effective at addressing stage 1 and 2 pelvic organ prolapse. And then even if you have a higher stage pelvic organ prolapse and you want to go through with therapy, then physical therapy can be, with surgery, it can be a really good way to kind of prepare for that surgery to improve your recovery after. And then there's research that shows that 6 months of supervised pelvic floor training can help improve your anatomical and symptom, or your anatomical dysfunction or your symptoms. So typically with any kind of skeletal muscles, 4 weeks is more about motor control changes and neurological changes. And then after the 6 to 8 weeks is when you get actual hypertrophy of those muscle fibers and increases in strength because of actual muscle growth. And a lot of research is done for about 12 weeks. 12 weeks is usually like the recommended amount, but typically it'll go longer than that. So I just wanted to go over a little bit about what the eval would look like. So it's similar to any other physical therapy evaluation where you have the subjective portion of the exam and you have your objective portion. So in the subjective, you're going to get asked a lot of questions about your medical history, your past medical history, musculoskeletal history. So any injuries that you had, any surgical history, whether that's related to abdominal surgeries, GI surgeries, colorectal surgeries, or, you know, a cesarean section. So all of that is important because it's affecting those abdominal muscles in that area. So that's why a review of systems is super important, because the physical therapist can kind of notice or refer a patient who might not be appropriate for physical therapy. Or it could be something that's done kind of with another doctor working together. And then they can also screen for signs of urinary incontinence. So it might not be something you're aware is an issue, or maybe it is, and this is the first time someone's bringing it up to you. And then also with the pelvic organ prolapse, it's something that can be screened for. And then so for the objective assessment, this is where it's a little bit different, because you have your external examination where you're looking at things like your alignment, your posture, and you're also looking at abdominal scars and transverse abdominis activation and presence of the diastasis recti, but you're also going to look internally. So you're going to examine the pelvic floor musculature, you're going to look at strength and endurance, you're going to look for the tissue support, so connective tissue in the fascia, if that's providing the support that it should be, and if maybe that's where your issue is coming from. And that's not required, that's just another tool. So some people might not need that part of the examination, then we wouldn't do it. Or if you don't feel comfortable, that's not something that's required. So the other thing that I wanted to mention is that if you're not sure if pelvic floor physical therapy is appropriate for you, then what you can do is schedule a consultation with me. And so we can kind of talk and see, it's like a 15-20 minute meeting where we'll just kind of discuss what's going on and see if physical therapy is appropriate or if you should see another medical professional. Oh, okay, that's it. I'm done talking. Now it's your turn. I'm going to pause this or stop sharing my screen. Okay, all right. Does anybody have any questions? I don't know if I can. Okay, I don't see any questions in the chat. So are you guys able to unmute yourselves, or do I have to do it? Someone try.
Yeah, this is Karen. I am muted.
Okay, thank you. All right, so if anybody has any questions, I'm just going to hang out for a little bit. So you can either send it in the chat, you can unmute yourself and ask your question, or if you don't feel comfortable, you can always email me and I can respond to you that way. My email is just my name, jessicavallenduke@gmail.com. But I'll just hang out a little bit. But if you're done, then thank you so much for coming. I'm going to just be here for like 10 minutes.
This is Karen again. Thank you for doing this. I think it's an important topic. I am a nurse in women's health. We do send patients for pelvic floor exercise. I wish this was around when I had an 11-pound, 4-ounce child many, 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 many years ago, because I'm paying for it today dearly. But it's important, and I thank you for doing this.
All right. Well, thank you for coming.